elegant faculty with us, and me and Dr. Jain, we thank the organizers for giving this opportunity. May I request Dr. Jain to start the proceeding, please?
First talk is Simplifying ROP Surgery by Dr. KairobiLahiri. Are you ready?
Yeah, I'm ready.
Please start.
Good morning, everybody. ROP surgery, I will try to simplify it for you as much as possible. What I'm talking about is stage 5 surgery, and this is a challenge in itself, as the anatomy, as you see, is totally disturbed. These are the very sick children that you see who develop this problem, and the question is, should we operate on these cases of stage 5 ROP? Because as you know, it's a to be or not to be situation. The amount of successes are very less, but should we do it or should we not do it? Now these are stages these are cases of stage 5, where you see in a gradation factor where the first one would be an easier one to tackle, this would be a little more difficult, and this would be one of the most difficult kind of cases to tackle. Now, what are the surgeries which are there for ROP? That is the open sky vitrectomy, the closed vitrectomy, the lens sparing vitrectomy, and in normal just exudative detachments involving just this with no traction, you can do a buccal. What are the prerequisites for this surgery? And ultrasound is of prime importance because as you see that you have to see the kind of funnel that you have in these cases, whether it is closed posteriorly or it's open posteriorly. And if you see the chart on this side, this has the worst prognosis and this has the best prognosis. So you have to talk to the patients accordingly. Now you require a good anesthetic team, a very capable, all the warmer blankets, etc. are required for these little babies so that they don't go into hypothermia. Good instrumentation, sharp instrumentation. Basically, a scissor and forceps is and an occutome cutter is what you require. Now, what are the steps of surgery? The steps of surgery are, you see, there are tractions along all these meridia, and you have to relieve all these tractions because unless you relieve these tractions, it's not going to help. So, what are the steps is that you do a belt buckle first, then you do an entry, then a lensectomy, and then a retrolental membrane dissection, then you open up the anterior loop funnel, opening up of the funnel thereafter, and viscoelastic injection, sometimes a SRF drainage, and then a closure. So stepwise approach. Now first, when we talked about buckle, this is what you put a belt buckle, which is at the equator, and you have to place it either with sutures, or you can make pockets in the sclera and put the buckle through that. So the choice is yours, which way you wish to do it. It's blanked out. आगे जा रहा हूँ. कुछ नहीं. It's gone dead. Huh? Sure. Hang हो गया? Oh shit. नहीं वही shutdown नहीं कर रही है.
Friends, till we have the slides restored, few things that questions will be taken, but will be taken at the end of the session. And may I request all the speakers to stick to time so that we have time for the question answers.
Take somebody else over there.
Okay, Dr. Guha, are you ready with your presentation? Yeah, please, till this is sorted out, can you, I'm sorry for this technical glitch. The next talk is tips and tricks for the MIVS. For the beginners, it is going to be a great presentation. Kamal Kishore, no. You are ready? Okay, sorry. Dr. Kamal Kishore is going to talk to us on SRF drainage through peripheral break. That's very interesting. Let's understand from him. How does he do it? Over to Kamal.
Good morning. Thank you for the opportunity. This is a basics class. So before we talk about SRF drainage, couple of milestones in vitrectomy. As many of you know, it was invented by Dr. Makimir in 1971. My teacher, Dr. Payman, just a few months later, invented the first guillotine cutter. O'Malley and Hines actually invented a 3-port system in 1972. And Dr. Payman invented endo-eliminator in 1976. In early years, there was either external drainage or no drainage. This is a paper from 1974, and it says that it's not necessary to drain subretinal fluid. Spaces to inject the gas bubble can be obtained by aspirating fluid from the vitreous cavity after vitrectomy. But simultaneous internal fluid exchange, or as we call fluid exchange, came from Steve Charles' work. And those are his exact words, to address the problems of sequential exchange, hypotony, incomplete drainage, and having to insert a needle in a deflated eye. So what are the options to manage subretinal fluid? One of them is a drain retinotomy, which can cause bleeding, proliferation, vascular occlusion. As you can see on the right, you would not want something like that near the macula. Or perfluoron, PFCL, assisted drainage, and the risk is obviously subfoveal PFO. So these are the steps of drainage through a peripheral break. First, you amputate the flap and mark the break as usual. Second, make the break as dependent as possible. And to do that, first of all, do not tape the head. Most of my cases are done under local anesthesia, and turn the head and rotate the eye as needed. And you always consider it a 2-step process. First, remove the SRF by suction as much as possible, and then think of exchange. Use a 25 gauge cutter with port facing anteriorly, almost touching the RPE. What that does, it prevents retinal incarceration, and it allows vitreous to be removed if it is present. And you can see here, this is a typical detachment with inferior break. And this is my cutter facing anteriorly, just touching the RP. And here you can see SRF being drained. And just by doing that, you can remove most of it. And notice this is just fluid-fluid exchange. There is no air as of now. And now the air comes. Stay there. Even though you are under air, you stay in the break until you have no more fluid to drain. And as you can see, almost entire fluid can be drained, and you can see the retina is quite well. There is just a little bit fluid left behind, and you can do it. This is another case. This is slightly more tricky if the break is superior. So again, rotate the eye and lift the patient's chin a little bit by about 10-15 degrees, and the same rules apply. You can see fluid being removed under fluid. Retina is almost flat. And notice no air yet. And now you get the air. Again, stay there. And now there is little bit fluid left behind that you can get. So this is a PVR case. Membranes have been peeled, and now retinectomy is being done. So when you do that, just cut anterior to your cautery marks or diathermy marks and excise anterior retina. Previously, at this stage, I would use PFCL, but not anymore, and you can watch it. So you rotate the eye down, and as the fluid is being drained, the jet of fluid is going to make this retina flat. And you can see it happening. See, this is going to roll into normal position very soon. And here you go. So this is my cutter. And you can see the aura. And you can finish it with your extrusion needle. Extrusion. And just walk along the entire edge of the giant tear that you created. And this is a laser. And that's it. So common mistakes. First is improper position. If your break is not dependent, it won't work. Second, if the break is too small. If that is the case, excise anterior retina with the vitrector. Is my timer? Third, vitreous plugging your soft tip. That's why I like to use cutter in the beginning. Next, going to air too soon. Wait until retina is almost settled. Wait until you are seeing choroidal pattern. Lower the IOP to about 25 and turn off IOP compensator. Next, going to nerve too soon. If you do that, then the air will seal the break, and then you will not get any more drainage. And last is avoid unnecessary movement. Just be patient. It will not take too much time. I know it sounds like a lot, but it will be very quick. Thank you.
Thank you so much, Kamal, for the small tricks, because that's where we go into the mistake of going to the disc and then we have a problem. Kairobi, are you okay? Okay, so would you like...
Should I restart or...
no, just take a few minutes to go through previous slides so that... Yeah, so that you catch up the audience with your slides. Yeah, please go ahead.
Okay. Sorry for that little mishap. This is ROP surgery simplified, and as I mentioned, this is a challenge by itself, as the anatomy is totally disturbed. These are the various sick children who are operated, so the question arises whether we should be doing the surgery at all or not. Now, these are different types of cases where you find that this would be the simplest to handle, this would be the next simple, and this would be the worst kind of case to handle. And we have different kind of surgeries which involves the open sky, the closed vitrectomy, the lens sparing vitrectomy, and the buccal. So what are the prerequisites? Prerequisites is a good ultrasound because you know what is the kind of funnel, whether it is closed posteriorly or it is open posteriorly, and it helps you to prognosticate whether the child is going to have a reasonably, this which would be about 20 to 25% in an open funnel and about 8% to 10% in a closed funnel detachment. A good anesthetic team with the warmer blankets and a good OT setup, and instrumentation which is good and sharp, and basically it's mostly the scissors and forceps and the cutter which you require. Now, what are the steps of surgery? The steps of surgery involve relieving traction along 3 planes. You see these 3 planes? These are where the tractions lie, and you have to relieve that traction, and the steps involve that of belt buckle. What's happening? A belt buckle, entry, the lensectomy, the retrolental membrane segmentation delamination, the opening of the anterior loop funnel, opening of the funnel thereafter, viscoelastic injection, SRF drainage, and then closure. So this is the buckle to show you. So this is a buckle which is placed at the equator of the eye, and you can place it with sutures, or you can make pockets in the sclera and pass the buckle through it, whichever is your choice. Now, after you do that, you have to make an entry. So suppose you're knocking off the lens, it's about a 0.5 to 0.75 millimeter behind entry from the limbus. And you can, if there is a space, you can put in your 23 gauge and be ready, but don't start it till you can see it. Until then, you can use AC maintainer to do your procedure. So this is what we are doing, is a lensectomy, where you remove the lens in toto so that it gives you space to work on the retrolental membrane very easily. And this has to be done in a stage 5 because the membrane is very close to the back surface of the lens. Now, in a closed funnel, the retrolental membrane dissection is important. What is happening? Okay, let's skip that. Now, this is, the previous one was with a curved scissor and the forceps, and this is with a vertical scissor and a forceps where you're going in, and slowly you're dissecting the, you're segmenting the membrane from the underlying retina. And how do you know which is the retina? The retina is the one which is off-white in color, whereas the membrane on top is white in color. So this is the retinal membrane dissection. You can do the same dissection with 2 choppers, where you go in and tease out, and it's a tangential traction in opposite directions, where you go right up to the ora. So you can see the enlarged, the ciliary processes, and that's where the anterior loop traction has to be addressed from, because if you open that nick over there, then you get the area where you can move all around throughout the 360 degrees. Now, after you do that, you have to relieve the anterior loop traction completely. This is a patient which was difficult because the cornea was a little hazy, and if you see that the membrane is quite thick, and what we are doing is that we are trying to get a nick into it by using a cutter, and then after that, you go ahead and separate it from the underlying retina, and lo and behold, then you get a small trough opening up, and that is what helps to relieve your retina, because it falls into place. Otherwise, if you have a contracted anterior loop, it will never fall into place and it never settles. Now, opening up the anterior loop is easier if the membranes are not so tenacious, and here you see that a little traction in both directions with your scissor helps you to get the cleavage plane. How do you know that the cleavage plane is not right? If you get bleeding, you know that your cleavage plane is wrong. So you have to alter, wait, raise bottle height, and then come back again. And then you have to go in and open up the funnel. Now, this is this which I have borrowed from Dr. Mahesh Shambhugam, and this is an outside in N block dissection, which he's doing a wonderful job that he's done. And if you see that he's carefully teasing out all these membranes which are there, which are connecting it, and then he's truncating it to the center. Now, when you work into the funnel, you have to be very careful because there are massive blood vessels in the core of this, and if you make a wrong move, you can land up with massive bleeds in that area, and you may sometimes have to close up. So opening up of the central funnel is important because once you come into this part, you have to open slowly. The membrane within this is very thick, so you have to just truncate all around it and open it, and then open up the whole thing with Helon. So this is another patient which I'm showing you where, again, the buckle was done through sort of entry ports into the scleral pockets. And after you've done it, you place the 23 gauge, and there is a lot of hemorrhage. This is a patient post-Avastin. And why I showed you this patient? Because Avastin has made life so difficult when we have to do these surgeries, because the membranes are so tenacious, so stuck, that you find it so difficult. You see the thickened membrane over there, and to get a leeway or an entry into this kind of a membrane is an uphill task. You finally get it, you have to clear the membrane because the stake is long hours, and finally you have a small opening where you're working around it, and you just see the thickness of the membrane over there. And you have to work around it and get through your procedure. And at the end of it, once you've managed to do all the clearing, then the final part comes where you have to you've opened up this and you are injecting Helon through it so that you can open up. Now you see that this is partially opened up over here, but still there's a lot of resistance, so it means that you have further dissection to do. Now this is one patient to show you that one eye had an open funnel and one eye had a closed funnel. And in this we find that the open funnel is rather easy to do, which is on this side, where you see that you're dissecting and you've opened up the anterior loop, and it looks pretty okay, and you will be able to sort of go in and put your Helon and get a necessary opening of the anterior funnel. And in this, the surgeries take longer because the funnel has to be opened up, and you have to do it in a rather gradual manner. Here you see it's opened up, and here it's taking a little longer time for it to settle. But you open it in this. And remember one thing, that in these patients, you don't have to do any dynamic settlements. You relieve most of the traction, put in Helon and leave it. It has to settle for itself. And that settling may take anywhere between 3 months to 6 months time also. So you have to give it time even after that. Now this is a patient where a recurrence was there. And since the earlier surgery was good, where we managed to settle the retina on the table itself, it went back. There was a flail iris which went back and got stuck here. So we went ahead and released it, and it was a short procedure. Now recurrences like this, it's just a 5% of patients who go in for a surgery. Now next coming to a different kind of scenario. In this patient, what would you do? Do a buccal or vitrectomy? Obviously, you'll do a vitrectomy because there's a lot of traction. So a lens-sparing vitrectomy is all in these kind of patients, relatively a little more easier, so that's why I've shown it later. And here, what you have to do in lens-sparing vitrectomy is that you have to spare the lens, and you have to do minimalistic surgery, just enough to see that your posterior pole is clear and it's flattened. So here you find that there is a traction upwards, and you have relieved all the traction over there, and you have to go in and just do a little laser or whatever you feel, or sometimes a diathermy is required if there is a vessel, and you go ahead with it. This is another patient where, again, you go in and do whatever is minimalistically required to relieve the traction, and then come out. This is a third patient where, again, this is Dr. Preetham has lent me his video because he did a very wonderful stage 4 thing, and this is where we are relieving this traction, and you leave the posterior pole intact, because the thing is that if the macula is attached, you don't have to do any further. And this is another patient where you did whatever was there to relieve the posterior pole, but there was a small bleed even before and after the surgery. In fact, it increased a little later. And these are few things which you have to be prepared for, and you have to deal with it. But if you can separate the hyaloid, it is a very good thing. Otherwise, you do whatever is required without creating much breaks. I won't show you this video. Now, these are just few of the results. This is a stage 5 operated. This girl is big by now, and this is the way her retina looks. A lot of subretinal deposits are there, but not much of vision. This is another girl who's now 16 years old. One eye, both eyes stage 5. One eye did well. One eye she's managing, and she's finished school with 75% marks. I'll just take a minute more. Stage 5, thiacical eye, one eye, and fold in the other eye, but still she's also doing school and doing pretty okay with that eye. This is another patient, one eye gone thiacical, one eye doing whatever work she's doing it with one eye. This is a better scenario, one eye laser doing very well, operated other eye is okay, supporting the right eye. This is a stage 4 doing okay, stage 5 in the left eye, but her maximum activity
Karobi, your
is the right
slides
eye.
have been switched off.
Just
so
1 second.
Yeah,
And twins? Okay.
they've been switched off.
So, and then finally, the final thing is rehabilitation, where you have to do a good rehabilitation for these patients, because otherwise it undoes whatever work you've done. So in conclusion, I would like to say that however difficult it may look, however frustrating it may look, however poor the results, never give it a miss, because this is the only chance that the child has. Thank you so much.
Thank you, Kairobi. The next talk is on tips and tricks for MIVS by Dr. Jayant Guha.
Thanks, Professor Jain Sahab, Dr. Agnihotri, and thank VRSI for this kind invitation. And it gives me great pleasure in giving this talk, tips and tricks for MIVS. Now, we all know the journey of MIVS from 20 gauge, 17 gauge to now being minimally invasive and minimally traumatic surgical procedure is now well advanced. But what is the desired destination? 27, 29, 30? So just tracing the history from 1996 to up to now, Oshima with 27 gauge, all these great contributors, stalwarts who have blazed the pathway. And we all know the current armamentarium. We have a full range of 23, 25 and 27 gauge with forceps, with vertical scissors, silicon tip DAC thrust cannulas, DDMS, ILM elevators, and extendable endolaser probes available for us. Now, the first step is the critical step is the trocar entry. So we all know that we have to stabilize the eye with forceps and begin angled entry anywhere from 0 to 30 degree, and then make it perpendicular and insert the cannula. And important point is not to rotate, but sometimes with reuse, we might have to rotate a little bit. And then cannula stays in place, and then attach the infusion to it. Now, this is a schematic diagram showing the same methodology, which will be shown in the videos also. So, just to revise, flatten the sclera to make the wound longer. The longer the cord length, the better is the valve effect. And the wound construction, as I said, is critical in MIVS. The three main steps: displacing the conjunctiva away from the sclera, prevents the vitreous wick from extending external to the conjunctiva. Flattening the sclera in insertion provides a longer chord length, as I described, and angling the incision to seal better. So we have to, the important moot point is try to see that the wound doesn't leak. These are the advancements in the trocar blade designs so as to ensure a linear design, as you can see in the graph. And the advent of the valved cannulas, with its advantages of maintaining the IOP at the surgeon-selected settings with negligible leakage and reducing incarcerations, is one of the most significant advances in fluidic stabilization of the eye. It does not allow fluid reflux from the eye and facilitates smooth instrument exchanges and eliminates the need for sclerotomy plugs. We all know the disadvantages of a non-valved trocar without going into details. Now, as the insertion is critical, the removal of the cannula is equally critical. So always clear the cannulas, ensure that it's clear from inside. Insert a blunt instrument is a good method. For example, light pipe, inserting before removing it, and then press and massage the sclera with a cotton clip close to the wound with the infusion pressure around about normal. If pressure drops, inject some BSS into it, and if still the leakage persists, never hesitate to put in a transconj suture, 70 or 80, and check IOP in the early postoperative period. So these are the following things which can happen while we are inserting the cannulas. There can be a suprachoroidal infusion, and immediately we have to evaluate the trocar positions. The good thing about it in MIVS cannula-based system is that you can change the infusion port, interchange the infusion port, and then the choroidal infusion will normally subside without any further action, and we can always choose a fresh site. The other thing which can happen is extrusion of the trocar cannulas. And if the cannula comes out, then there are methods to, I won't go into the details, to reinsert to the same site, or if there is large ballooning of the conjunctiva, you reposition it. And so the assistant has to be very vigilant so as to not to allow this sort of a thing happening. So the good method, the good steps are to tape the infusion tube into a position that stabilizes the cannula, and make sure that the infusion cannula is not too far below the 3 and 9 o'clock meridians. And changing the position of the infusion cannula during large angles of rotation, you have to be very careful. And as I said, the assistant has to be very vigilant. We have a lot of, the probability of the cannula displacement very high in Marfan's and high myopes because of the thin sclera. And it's very important tip is to, when you are using forceps and scissors, to close them before you're taking out through the cannulas. If you're not vigilant, then there can be retina touch through the instruments, and especially important when waiting for a change of instrument to be handled by the assistant, where the light pipe is, you're holding light pipe with one hand, you have to be very careful not to allow the light pipe to slide in and out. So another thing is that there are ways to prevent iatrogenic breaks and result in RD prevention. The trocar systems, the advantage is that it inherently protects against the retinal tears. But the greatest concern is not to incarcerate the vitreous into the trocar, especially using non-valved cannulas when entering the eye, and especially when you are exiting with an instrument. So it's a good method that I often use, even in phakic eyes, is to clear the vitreous around the cannulas at the beginning of the surgery. That helps a lot of problem. We can, the further steps to reduce the prevention of breaks is by keeping the cut rate high and flow rate modest, and taking, as Steve Charles says, taking the port to the vitreous and not engaging and pulling the vitreous. So good protocol is to inspect the eye at the end of every case with depression to ensure that the patient doesn't have a retinal tear, and closing the lumen while you exit the sclera with the light pipe is placed. As I said earlier, we ensure that there is no ostium as we exit the sclera, and exit slowly while supporting the sclera with the cotton bud. Wound leak hypotony has to be prevented at all cost. Hypotony, even if transient, is not a benign condition. It may increase the postoperative risk of incarceration, suprachoroidal hemorrhage, and endophthalmitis. So suture, always suture when in doubt, as in this case. You massage it. As you see, if there is any leakage, always place a suture. So I'll straight away go to the videos. There are impossible situations when sometimes you can switch your thing to a hybrid management. For in this case, but in these situations, you have to do 20 gauge. There is no other options because of the multiple instruments that you have to use. This is large submacular hemorrhage that we had tried to take out successfully. So you had create a 360 retinotomy, and then you take out that huge clot from underneath the retina. So that's an impossible situation. You can't use MIVS. But here you can use a hybrid. You can enlarge one port while taking out this foreign body out. So I'll just run through assortment of cases that you can do 23 gauge. This is a case of diabetic TRD, and we saw some very good videos by Dr. Kamal in the morning. And the cross section of the tips of the 23 gauge scissors are so small, it prevents very little, it creates very little collateral damage. So using the forceps and scissors combination, you can work across your tabletop membranes very effectively while maintaining a 23 gauge situations. I just have 1 minute more.
Your slides will be switched off, after this. So
Okay.
please kindly wind it up.
Okay. So I just, there was some silicone oil removal cases, there was complex RD situations, which we can all manage with 23 gauge surgeries. So it takes less time even than 20 gauge for all the oil to come out. The last bit might have to be actively aspirated, the last single bubble. Thank you very much.
Thank you so much, Jayant. May I now call Professor Marc to come and talk to us about persistent SRF post-RD, what to do. Over to Professor Marc. Please keep your questions ready. And for the delegates who are standing, there are some chairs available here. Please come forward and occupy them. There's some chairs on the front row which are still available to you. It's here on the front row. There are some chairs.
Well, thank you very much.
Sure.
So what should we do in the case of post-retinal detachment subretinal fluid? And what I'd like to do is to go over, in some ways, how frequent this problem is, discuss a little bit what may, in fact, cause this problem, and talk about maybe some of the solutions and things we should think about when we're in presence of this problem. So there are a few studies that have come out. I'm sure that most of you that deal with vitreoretinal surgery and retinal detachments have come across this problem on more than one occasion. And so there are a few studies that are out there. One of the first person to report it was Wolfensberger about 20 years ago. And he reported it in a study with 33 patients looking at the persistence of this fluid, and found that it was mainly associated with patients that had undergone a repair of a regmatogenous retinal detachment with a buccal. He did not see it in the presence of a pars plana vitrectomy. Benson more recently has looked at the same issue, found that it was present subretinal fluid in up to 55% of patients for up to 6 weeks after having done a buccal procedure, while it was present in maybe 15% of patients that had undergone a pars plana vitrectomy. So it isn't an uncommon problem, although one that usually disappears on its own. One has to say that as the fluid gets out of the macular area, usually there's very good recovery of vision, although 100% vision does not always come back. You may end up with a slight reduction in vision. There are quite a few patients, in fact, that after you've done a buccal seem to have a perfectly anatomically correct result, yet the vision hasn't recovered, and when you do an OCT, you find that there is some fluid in the subretinal space. So which surgical maneuvers may contribute to the problem? Well, ischemia has been considered as being one of the major factors that might be causative, and here if we're using an encircling element, certainly that is causing some choroidal ischemia, this may in fact be a major contributor if the buccal itself is very large. But I've also seen it when one uses segmental buccals, just a sponge to close a small peripheral tear in a patient with an attached posterior vitreous. And in one occasion, this fluid persisted for more than 1 year. The amount of cryocoagulation that is done might be a contributing factor. Certainly, if you put a lot of cryo, you will cause some inflammation inside the eye, and the inflammatory episode itself may cause an increase in the amount of fluid, although this disappears over time quite quickly. And in the study performed by Wolfensberger, he did not really see any difference in the, he used cryo in all of his cases, but there was no difference, of course, between the pars plana vitrectomy versus buccal. And in those patients that had received the pars plana vitrectomy, there was in fact no subretinal fluid. Tamponade is used, of course, quite frequently, and you do get displacement of the fluid into the subretinal space. With pars plana vitrectomy, this may be a contributing factor. There's very often fluid that is left behind at the end of surgery, and in fact, doing a complete drain is not an absolute necessity. This does not seem to be a major factor. Displacing fluid that has been in the periphery is not usually the cause of the appearance of this problem. Inadequate drainage might be, certainly if we've had some fluid that has been persistent in the vitreous for in the subretinal space for a very long time. Probably more important are some of the physiological parameters. There are biochemical properties for the subretinal fluid. The fluid tends to be thicker. It contains a lot more elements from the RPE as well as the shedding of the retina as the fluid is persistent for a long time, so that it creates a high oncotic pressure. This high oncotic pressure limits the reabsorption of fluid, as I'm sure many of you are aware when you're dealing with a chronic detachment. RPE pump dysfunction is probably one of the most important factors for this persistence. There's decreased phagocytic activity in chronic retinal detachments, and many of the patients that have this persistent fluid very often have some other factors that are present. Looking at the pathophysiology, retinal detachment is an active process. It's a metabolic process where water is being transported out of the eye through both Mueller cells and the RPE. The attachment is in fact necessitates a normal function, so if there's dysfunction of the RPE or increased oncotic pressure, there will be a less tendency for the retina to reattach. This brings us to some other metabolic factors that might be important. There is a pressure gradient that exists from the vitreous through the retina, through the sclera into the outside of the eye, so that you should consider as one of the potential factors the presence of a ciliary choroidal effusion process. If you have a very thickened sclera, this may in fact limit reabsorption. And I've certainly seen 2 or 3 cases such as these where we get an increase in the amount of fluid in the subretinal space even after repairing the retinal detachment. And it's only by creating a partial dissection through the sclera that we were able to eliminate the fluid and make sure that the retina reattached. So it's a little bit like having a process in which we have a thickened sclera. Posterior scleritis might be a possibility. Certainly if we're putting a buccal on the eye, there are situations do occur where you get a persistent inflammation. Consider also the possibility of having an infection. Infections don't always manifest themselves with a very high pain threshold, nor will they necessarily show very much inflammation if they're very localized inside the eye, and may be a cause of increased effusion and persistence of fluid. The primary RPE dysfunction that may occur might be due also to some systemic factors. For example, the presence of hypertension should be considered. Inflammation such as VKH, scleritis, as we've already mentioned. The presence of the use of other medications such as steroids if a person has any arthritic symptoms or toxicity to certain medications. Also consider the presence of some tractional component within the eye that might be in fact pulling on the retina and preventing it from reattaching, in which case you may have to consider a reoperation. What are our therapeutic options? Well, first of all, rule out inflammation. If there is inflammation, you should treat it with local steroids preferably, and if that doesn't work, the use of oral steroids. You may consider stimulating the RPE pump. The easiest approach would be to use acetazolamide, although that doesn't work all that well. If the fluid persists for more than a month or two, I would consider the use of aldactone. Aldactone is known to stimulate the RPE pump. It is, for example, very useful in the central serous retinopathy. And in at least one case, it has been successful at eliminating the fluid that has been present in the subretinal space for more than a year. Somatostatin analogs, which are administered subcutaneously, have also been shown to work in a number of patients with persistent subretinal fluid. They work also in the RPE pump, as the RPE has some growth hormone receptors that allow elimination of fluid. I would only consider repeat surgery if there's a reaccumulation of fluid, which might indicate the presence of a secondary tear or reopening of the tear at the primary location. And one thing to consider with regards to prophylaxis in high-risk cases might be to do if you're doing a vitrectomy, a washout of the fluid in the subretinal space so that it becomes less dense prior to drainage, so that if there is any fluid accumulating into the macular area, it will be easier for the pump to eliminate. Thank you very much.
Thank you so much, Professor Marc. It was a wonderful presentation of this difficult clinical condition. The next talk will be by Dr. Gaurav Shah. Non-diabetic vitreous hemorrhage, early or late vitrectomy. That's a question which haunts us. And who else but Gaurav to tell us what to do? Over to Gaurav. Yeah, that's on.
Is that on? Okay, so first of all, thank you for the opportunity. I enjoyed Marc's talk because Marc talked about persistent subretinal fluid, so I'm going to talk about blood, the other thing that retina specialists are good at. So talk about early versus delayed vitrectomy for non-diabetic vitreous hemorrhages. And this is really a common dilemma because it's a frequent referral to our practices. Dense hemorrhage is really potential for urgency of diagnosis. Patients are uncomfortable, referring docs are uncomfortable. We typically use ultrasound, and really options are observation versus early surgical intervention. So this is the typical scenario, and this usually happens either Friday or Monday, right? Never happens on a Wednesday, right? So it's either Friday or Monday, and after you come back for a meeting, phakic patient, spontaneous dense vitreous hemorrhage, sent in for a retinal detachment, right? That's the typical scenario. Hand motions, vision, exams normal. Patient thinks they've got something really bad going on. Count fingers vision, poor view, no tears or breaks. So the thing we're talking about are really these grade 3 and 4 hemorrhages, if you break it down, is vitreous hemorrhages where it's very difficult to see the optic nerve, the disc, any of their vessels. It's just a dense hemorrhage, right? Not something mild. So the question is, what do we recommend? How long do we wait for it to clear? Does it matter if they're phakic, if they're pseudophakic, on blood thinners, other factors to consider? So these are not diagnostic dilemmas but these are common things that's going to happen to one of us next week, I guarantee you, okay? And if it doesn't, you're probably not in the office seeing patients. So the etiology is really retinal vascular disease, but I always think of this as what's going to do the greatest harm for this patient. Either it's going to be a retinal tear or a retinal detachment, right? Vein occlusions didn't kill anybody, but retinal tears and detachments can kill the eye potentially. So retinal vasculitis, polypoidal disease, or just a bad PVD. So if you look at the literature, there's actually probably less than 7 papers on this. It's pretty amazing, okay? And one of the papers, 2017, so these were patients who were not found to have a retinal tear detachment ultrasound, but intraoperatively what they found was about 60%, 68% had a retinal tear, 45% had a retinal detachment. What's interesting, as you see similar to our paper that was published this year, tears on ultrasound were missed. They were detected only 20% of the time, and detachments are only detected 54% of the time. That even in experienced hands, ultrasound is going to be quite variable, okay? So I think advances in technique have really made small gate surgery and vitrectomy safer. It's not It has its complications, but certainly safer. So we wanted to look at this group of patients into two different groups, whether it's 10 days or before or after 10 days. There's 13 of us in our practice, so people do practice a little bit differently, okay? So we reviewed, looking at our data from 2011 to 2016, hemorrhages that I described with non-diabetic, all underwent B-scan. If there was a high suspicion for tear or detachment, we excluded that group, right? So those are patients we excluded. These are the ones that says, I'm not sure what's going on. I'm going to wait or I'm going to do surgery. That's the key point. We looked at 275 patients, 276 eyes. 52 eyes of 52 patients are included in the present study. Now, this is a key take-home message. Average age was young, 61. Kind of keep that in mind, okay, when you look at this disease. Timing of intervention was at the, whoever was seeing the patient, delayed vitrectomy was surgery following 10 days. They all underwent small gate surgery, 23 or 27. So what's interesting, what did we find at the time of intraoperatively? Retinal tears, 48%. Retinal detachment, 24%. Vein occlusions, retinal vasculitis, macroaneurysms. So this is a take-home message. 75% had either a tear or a detachment. People don't get spontaneous vitreous hemorrhage typically for nothing. Like the vitreous is abnormal. Keep that in mind. If you look at initial and final visual acuity, there really wasn't a difference. So there's no difference in terms of visual outcome, in terms of final visual acuity. Type of operations, number of operations didn't seem to make a difference because, again, the numbers are small. But the sensitivity for retinal tears was 24% and for detachments, 58%. In a group of 13 retina docs who are used to doing ultrasounds, right? So either we all need to do ultrasounds again or we do miss things on ultrasound. Large number of detachments were missed on ultrasound. Now what's interesting, 16 of the eyes with retinal detachments, 12 were phakic and only 4 were pseudophakic. Greater percentage of eyes with detachment were phakic, but again, small numbers. You have, what we want to note is that the vitrectomy, even though it did not show a difference in early versus late outcomes, the odds ratio, if you're a phakic patient or retinal detachment, was 2.14 for having a retinal detachment in pseudophakic eyes. So really, that's important to remember because you know the vitreous in a phakic eye may not have separated completely, unlike a pseudophakic eye. So kind of keep that as a take-home message of a high-risk patient. So our conclusion from our paper that early vitrectomy, I certainly think is safe and effective. And with myopia now being problematic throughout the world, this is an issue. You're going to see more of these myopic young 40 and 50-year-olds are going to come in with vitreous hemorrhages. And if you don't believe me, these are 3 patients who were just seen in the last month. Somebody who has a vitreous hemorrhage like this, again, wouldn't be in the study, but what's important to note, this patient had 1 tear, 2 tears up above. At the time of vitrectomy, he had 3 tears down below where we would not have been able to see where the blood was, right? Another patient, tear up above, 2 tears down below where the hemorrhage had settled. Another patient who has this particular problem, blood, and then a giant tear. So the point is management of non-diabetic vitreous hemorrhages really continues to evolve as vitrectomy evolves. If they can't see you out, you can't see in. Real simple. A conservative treatment, I think, is appropriate for some patients, but you must follow them carefully. I would be very careful of young 40 to 60-year-old myopes, phakic, because they're going to be the highest risk to have a retinal tear and detachment. I would not just rely on ultrasound. So thank you again and appreciate the invitation.
Thank you so much, Gaurav, for a very lucid talk on this. You cleared a lot of cobwebs in our minds. Yes, there is a question. Gaurav, don't go.
Gaurav, excellent enumeration of etiologies, which we also see as a cause in non-diabetic vitreous hemorrhage when we do early vitrectomies. But with our perspective, I would like to just comment and add to your list. PCV
Yes.
is an important condition, and also there are few rare cases of peripheral hemorrhagic retinopathy which we encounter in our scenario.
Exactly.
So it's a beautiful list,
Like
which you have. Otherwise,
Eels disease, you mean? Eels disease is one
Eels
of them.
disease we see some
yeah,
patients with.
but Eels has kind of, as a cause of vitreous hemorrhage, has become lesser and lesser. And I would say his vascular occlusions cover that part. The Eels gets covered in the vascular occlusive part. But besides that, it's peripheral hemorrhagic and PCV.
Any question to
Sir,
any
I
other
wanted
speaker?
to ask, of all the 75% of the patients that you had with vitreous hemorrhage having some break or a retinal detachment, how many of those patients did clinically correlate with symptoms of flashes or anything of that sort?
So how many patients who had a retinal how many patients
Of
had
the
flashing
patients-
lights?
Yeah. Of how many patients did complain of that?
You know what? I have no idea. I could make up a number, but I have no idea just in terms of flashing lights. You could think of, maybe the symptoms were there of a detachment, but that wasn't always recorded, and that's a good point. But we didn't always record that in the history. Okay.
And while using 27 gauge, so what is the amount of bending of the instruments do you get while anything on that? Do they bend while you're manipulating inside the eye?
No, I mean, it's just like any small gauge surgery. I think, you get used to what you have. So I think the key message is really not how you do it. You could do the 17 gauge, 19 gauge, 23 gauge, 27 gauge. I think the key is to manage these patients. If you're going to follow them closely. Do not rely on ultrasound. But every time I've done a vitrectomy, I have never regretted that, boy, I shouldn't have done a vitrectomy. Because what's going to happen is the tears you see those are not the problem. It's the tears you don't see, right? It's when you have blood down below, that blood sometimes will take weeks and weeks for it to go away. And intraoperatively, almost 8 out of 10 times, we found a new problem down below. So when patients have 1 tear, 2 tears, that tells us the vitreous is abnormal. And I think it's important that we treat this disease in a manner that you can actually get good outcomes, right? Because if you have blood, untreated tears, you're at a risk to have a detachment that's going to have a much different prognosis than fixing it late. That's my point.
All right, thank you.
Dr. Gaurav, I have one more question. When you say we follow them closely, so how closely you expect them? So a couple of patients of mine, I already asked to follow them after a week, and they developed an RD. And when I asked to follow up after a week, and after 2 weeks, I noted an HST and I did it. So when you say closely, so is it 48 hours, 36 hours?
Yeah, I would say I think you follow them closely for the first week or 10 days, every couple of days. If and you have the patients look at their peripheral visual field, right? If they start to see, even though they can't see, the visual field should still be relatively intact, right? So I think you got to see them every couple of days. And if you don't want to do that, maybe talk about surgery, because dense vitreous hemorrhages, they just don't occur for unlikely reasons.
But how much cases with retinal tears you have noted that vitreous hemorrhage were dense? So what we have seen, there must be some clinical view spaces. They are not much dense when you have an HST or something like that.
Of course. So so those hemorrhages where you can see a tear, no problem, and a little bit of hemorrhage. These are just dense hemorrhages where you can't see any of the vessels or the nerve.
Thank you.
Gaurav, there was a teaching that you wait so that PVD occurs and vitrectomy becomes easier. What's your take on this?
Well, I think we all have teachings, but again, vitrectomy surgery has evolved, right? So I don't wait for bad things to occur. I mean, it's kind of like, if you have a flat tire, there's a hole, so you can wait for it to go flat or kind of fix the flat. So I think, if the PVD is going to occur, I would rather have it occurring in a way I can see it intraoperatively to take care of the problem in a safe manner, because then it occurs in an uncontrolled fashion.
True.
I'm going to maybe do it or complete it in a controlled fashion.
Perfect. Any other questions? We have another 2-3 minutes. Any comments? Yes, please.
You see younger patients with myopia. What was the most common refraction of myopia that makes this patient prone for retinal detachment?
So probably most, I would say a vast majority were minus 5.5 to 6. Okay, the typical myopic patient. Okay, and I think that this problem is only going to occur more. And this is a common dilemma. I can guarantee you, somebody in the room is going to have one Monday. This is how it is. This is retina.
Any other question, please? Yeah, Ajay? Any question on ROP? Because now Mangat is
Gaurav, you mentioned in the beginning about blood thinners. So normally in cases when you're doing a vitrectomy, this is just not for this presentation, would you like to stop blood thinners?
You know what, I think that most of us do not stop blood thinners unless, let's say if they're in Coumadin and their INR is going to be in the 3 to 4 range, interventional radiologists will do procedures when the Coumadin level or the INR is going to be about 2.3 to 2.4. So I particularly don't stop blood thinners. You know, if you have something like the near blood thinners, you can't really even get a level, right? So we typically don't stop it because I think there's a greater risk potentially from having a stroke rather than me having an issue. So issues can occur, but we typically don't stop them.
If you have a patient, a diabetic vitrectomy, and the patient is on, say, dialysis, so would you ask him to shift from a heparinized to a non-heparin dialysis?
I would have a conversation with their internist, yes. Okay. Yes, but a diabetic patient who has any issues with blood thinners, they're already at high risk for having a stroke. Now we have some medical legal cases that people have stopped blood thinners, has a stroke, before typically cataract surgery or vitrectomy, and now we have an issue of a medical legal problem because stopping the medicine is potentially portrayed as greater risk for having a stroke. So, you know, we have cautery, so that's what you do.
Any other question? Do you ever use anti-VEGFs in these patients? Do you ever use anti-VEGFs in these patients?
So the question is, in dense vitreous hemorrhage, do I? You know, I don't, because I'm not sure what I'm treating, right? So I would hate to use something that, if I knew it's a vein occlusion, of course, but if I don't know, then again, I feel uncomfortable. I'm not sure what I'm treating.
Actually, we had been using this anti-VEGF, especially in patients with diabetic vitrectomies, and I think in the November issue of Ophthalmology Retina, just the last issue, there is a paper which says half-dose bevacizumab preoperatively in these cases actually reduces the incidence of vitreous hemorrhage after surgery.
Yeah, no, I think his question was in dense vitreous hemorrhages, not diabetic.
Okay. We are not talking about diabetic. It is a non-diabetic thing. Yeah. Thank you so much, Gaurav, and it was a pleasure to chair these sessions. I and Dr. Jain, we thank the organizers. May I now call the next chairperson for the next session, session 6, Dr. Kamlesh and Dr. Kamal Kishore, to carry forward. Thank you.